Thank you. Siddharth is not here, but I'd like to thank him for inviting me for this instruction course. So this is a huge topic to cover. So I'll be talking about the insights that we've learned from anterior segment imaging, ASOCT and UBM, and very briefly on some advances. So as we know, angle closure is a complex heterogeneous disease, which is primarily a disease of the anterior segment. And established risk factors for angle closure include shallower anterior chamber depth, axial length, and increased lens thickness. However, studies have also shown that angle closure is not fully explained by these known risk factors. So with the advances in imaging technologies such as the ASOCT and UBM, we are now able not only to visualize the anterior segment, but to also perform quantitative measurements of the different anterior segment structures. And this has helped us to better understand, the mechanisms for angle closure and to detect them, and also helped us identify novel risk factors for angle closure. So I'll go through these very briefly. So based on the AIGS consensus statement, AIGS is the Association of International Glaucoma Society consensus statement, angle closure mechanism is characterized as being being caused due to forces acting at 4 anatomical levels. Level 1 is at the level of the iris and pupil, that's pupil block. And level 2 onwards is forces acting behind the iris, which means that in this case, the difference between ASOCT and UBM is that UBM allows imaging of the structures behind the iris. So in terms of UBM, I'll be talking about plateau iris and retroreticular, that's uveal effusion. So plateau iris configuration, this is, so the difference between plateau iris configuration, plateau iris syndrome is very similar findings, except that the findings, plateau iris syndrome is the same, similar findings in an eye with a patent iridotomy. So this is diagnosed, plateau iris configuration is diagnosed gonioscopically as the presence of occludable angles with a flat iris plane and centrally relatively deep anterior chamber. And the hallmark of diagnosis, gonioscopic diagnosis, is the presence of a double hump sign. However, I'll talk of the imaging modalities for identifying plateau iris on UBM. And as I said, because the reason for the plateau iris is because of forces acting behind the iris, that's why it's not, ASOCT is not the best imaging modality. It requires the UBM, because UBM helps us to confirm the presence of the anteriorly directed ciliary processes and presence of an absent ciliary sulcus. So what happens in plateau iris is the anteriorly directed ciliary processes pushes the peripheral iris upwards, and that's what causes the irido-angle contact or the angle closure and the angulation that is seen. And of course, pseudoplateau iris are due to abnormal pathology of the ciliary body, such as cysts or tumors. Now, I think Arjit has touched upon plateau iris. I'll just talk about a bit of the epidemiology, because it has been found across different ethnic groups, be it Western population in Singapore and as well as in Indian populations, that studies indicate that about 20 to 30% of patients with primary angle closure have plateau iris after an iridotomy. And the risk factors include a female preponderance, hyperopia, younger patients, and those with a positive family history. And this was a paper where we looked at not just the overall prevalence or proportion of plateau iris in angle closure, but across different disease severity. And we found that there was a significantly greater proportion of plateau iris in patients with severe PACG compared to the early moderate PACG. And these patients with severe PACG were also characterized by having a younger age of onset, high presenting IOP, and greater extent of peripheral anterior synechiae. So this suggests that plateau iris may be a contributory factor for disease severity. And of course, a younger age of onset could either be because they developed disease earlier, or they underwent rapid disease progression. So plateau iris is often under-recognized. It's an important cause of angle closure, but probably perhaps under-recognized. And likewise is uveal effusion. It's probably under-recognized, and it's more common in secondary angle closure, but it's also found in eyes with primary angle closure. So Quigley postulated that choroidal expansion may either precede or even precipitate angle closure. And what he postulated was that in small eyes that are predisposed to develop angle closure, choroidal expansion pushes the lens iris diaphragm forward, and that causes closure of the angles and elevated IOP. So in this paper from 2003, Hiroshi Sakai, what he did was he imaged patients, performed UBM in patients with angle closure, and defined a grading system for uveal effusion based on and compared it with the patient's the ciliary body size as slit-like, band-like, or obvious ciliary uveal effusion. So both in the Japanese as well as in the Singaporean predominantly Chinese population, this is primary angle closure. It was found in about a higher proportion in acute angle closure and about 10 to 15% in primary angle closure. Whether this is significant or not, whether it's going to change our management or not for primary angle closure, I don't think so, but definitely in cases of secondary angle closure with the presence of inflammation, uveitis, or even medication, topiramate-induced, I think identifying the presence of uveal effusion as a cause for angle closure, sometimes treating that or removing the cause actually results in resolution of the uveal effusion. So uveal effusion and plateau iris, these are often under-recognized or under-picked up, but UBM helps us in identifying these disease mechanisms. So coming to ASOCT, I think the initial ASOCT that was the time domain ones, what they had was they only had calipers for measurement of the different parameters. And so a lot of institutes developed their own customized software. So the ones I'm familiar with is the Zhongshan Angle Assessment Program. There's the academia as well as the ASAP. So all of them kind of give a similar output, which is measurements of the angles, the anterior chamber, lens, and iris. So I'll just go through the risk factors that were identified for angle closure. So in this study from Tin's group, they found that patients with angle closure had a significantly greater iris curvature, iris thickness, and iris area. Likewise, we found that anterior chambers, eyes with angle closure had smaller anterior chamber width. Anterior chamber width was defined as spur to spur distance. Also small anterior chamber area and volume. And also one of the parameters from the ASOCT is the lens vault. And this is defined as the distance, it quantifies the extent of lens that is located anterior to the anterior chamber angles. And it's been found to be a better marker for assessing the role of the lens in angle closure. I'll speak more about this in the next session and the next talk on the lens. So these imaging-based, not just risk factors, also mechanisms have shown that angle closure is not a homogeneous disease and that the anatomical risk factors may be different in different individuals. And several groups have actually looked at whether there are subgroups of angle closure based on anatomical factors. And using the different ASOCT-derived parameters and cluster analysis, most of the groups actually have found that angle closure can be categorized either to two or three clusters, predominantly having either a lens component, an iris, or an intermediate group. And so following this, what Kyungrim's group in South Korea have done is they actually look at the outcome of LPI, predominantly angle widening, based on the cluster analysis using quantitative subgrouping, as well as another study looking at qualitative, subjectively classifying the different presumed mechanisms of angle closure. And what they found was that different presumed mechanisms actually behave differently. For example, those due to a pupil block had wider opening, plateau iris, smaller opening, as well as thicker iris had a much smaller opening compared to the ones with pupil block. However, this is just based on the treatment, the LPI alone, and more studies are actually required to see if there are the effect of other treatment modalities in order to identify what is the optimum management strategy based on presumed mechanisms. Now, coming very briefly on recent advances, well, not very recent. So this slide shows the evolution of the ASOCT from time domain, spectral domain, and now we have the swept source OCT. Cassia has been around for a while, and now the Interion from 2019. So this provides, these two imaging modalities allow the capture of 360-degree circumferential capture of the images. So this is, so what the Cassia does is it captures 128 sections across 360 degrees in about 2 seconds. So the Cassia has an inbuilt software for measurement of the iridotrabecular contact, or the ITC index, which gives a measurement of the extent of angle closure as a percentage. And the new Cassia 2 has an inbuilt image analysis software called the STAR 360, and unlike the other ASOCT, which only provides measurement of the lens vault, this also gives measurements of the lens curvature and the entire lens thickness. And now in the last couple of years, there's been an explosion of papers looking at AI and machine learning, deep learning on automated detection of angle closure. I'll not go through them, but I can direct you to this paper that it's recently published in PRER last year, where we looked at, we provided, it looks at a comprehensive evaluation of the different AI algorithms and methodologies for angle closure detection and evaluation. And this is something new, the IRIS OCT angiography. I don't think there's been any papers published yet, but something to look forward to, perhaps in the near future, where we may have some functional mechanisms of the iris as a mechanism for angle closure. So in summary, ASOCT, both anterior segment imaging have provided not just an objective method to assess the angles, but also shown us that angle closure is not a homogeneous disease. However, there's still a lot of work that needs to be done, prospective longitudinal studies to look at what is the optimum management strategy based on mechanisms, role of AI to mainly in kind of a multimodal kind of environment where you do, if it's possible to do ASOCT, UBM, or clinical features for a patient, and also for personalized management, and also to look out for potential more clinical applications of the newer ASOCT devices. Thank you very much. I think I'll skip this.